Well, hello again, everyone. Welcome back. And we have exciting panel discussions still to come. So without further ado, let's begin. In this session, we will hear from Dr. Kotiah, who will give an overview of NANETS 101, and then we will join a panel of diverse net care medical professionals for an open forum conversation, allowing for a robust question and answer between our patients and doctors. This session offers CME credit to medical professionals who have joined us. You can earn AMA, Category 1 presidents, MOC in nursing, and continued education credits. A link to obtain credits was provided pre-conference and will be sent to post-conference to all registered participants. Now, I would like to introduce our first speaker, Dr. Sandy Kataya, Director of the Neuroendocrine Tumor Program at Mercy Medical Center, will be giving us a comprehensive overview of NANETS 101. Dr. Kotiah.
Thank you.
Get away.
Sorry, thank you very much, Dr. Odoricio. So I'm gonna just go over things that I would like my patients to know as much as possible when they come to see me in the office. Just sort of my take on it. The title is NANETS 101. That was inspired by Lisa Yen at the LAC-NETS group, and I thought it was a great title. So I'm just gonna move forward here. These are my disclosures. So, I tell my patients that neuroendocrine tumors are tumors that come from hormone-producing cells that are either scattered in your organs or they come from hormone-producing glands. So the ones that are scattered in the organs, the most classic example of that is a small bowel neuroendocrine tumor. And then the one that starts in hormone-producing glands is, for example, the pancreas. And these neuroendocrine cells can produce hormones when they're stimulated by the nervous system to control different body function. So for example, the pancreas makes insulin and glucagon to control blood glucose levels or blood sugar. So, there are lots of different areas where neuroendocrine tumors can start. We usually deal with the GI tract, the small bowel, the pancreas also, and as well as the lung, but there's also ovary and prostate in very rare areas. But the most common ones are usually the small bowel, the pancreas, and the lung. So there's lots of terminology with neuroendocrine tumors, and it can get very confusing even for people who treat neuroendocrine tumors. So I decided to sort of put some of the terminology down here. Neuroendocrine tumors usually refer to slow-growing tumors that can potentially spread to other organs, especially the liver is the one that we're more concerned about. Neuroendocrine carcinoma means that you have a more aggressive cancer, it's faster growing, and it usually does spread to other organs, and it can be acutely life-threatening, like small cell lung cancer. Carcinoid is a type of neuroendocrine tumor that is slow growing, that can potentially lead to carcinoid syndrome, although most of them are not usually producing a lot of hormones. We're trying not to use the term carcinoid anymore because there's a tendency to confuse all neuroendocrine tumors with carcinoid, which is not the case. And then neuroendocrine neoplasms mean that you could have any kind of neuroendocrine tumor, whether it's any kind of neuroendocrine process, whether it's a neuroendocrine tumor or a neuroendocrine carcinoma. And then the term functional neuroendocrine tumor means that your tumor is a neuroendocrine tumor that can produce a lot of different hormones, which again is the minority of patients. So what's important for you to know, your pathology report is a good starting point for us, although it's not the end all be all. We look at different information on the pathology report to kind of start to guide your treatment. And if you have a slow-growing tumor or a fast-growing tumor, when you have a slow-growing tumor, we usually ask ourselves, is this tumor producing hormones? Are you having symptoms from that hormone production? Do we have to do something about that right away, which we usually do? And then the hormone production can be different depending on where your cancer started from. So the small bowel can make serotonin, the pancreas can make too much insulin or glucagon. So, not all the locations make the same type of hormone. And the location of your primary tumor is important to us in some ways because it can change your treatment options. It's not always possible to see where it started from, which is the reverse of other types of cancers that we deal with, where usually where it started is a very big mass and where it spread to is very small or a smaller type of spread. But neuroendocrine tumors, the primaries can be very small, but the spread to the liver can be more impressive. So if we try to know that. And then the stage of your tumor tells us what kind of treatment you need to have, because if it's something that's still localized, it hasn't spread, we try to offer localized treatment like surgery. If it's something that's spread, then of course we try to use different modalities, including, potentially surgery, potentially drugs, which we'll talk about a little bit later on. And we have imaging to help us stage your tumor if you're not able to have surgery. So the pathology, usually we look at different pieces of information. We look at the differentiation, which is how does it look under the microscope? So the pathologist tells us that information. Well-differentiated tumors tend to behave more like normal hormone-producing cells. Fully differentiated tumors, they look very aggressive, very ugly under the microscope. We can't always tell where it originated from, except that we biopsied that area. So that's sometimes how we know that it started there. And then we look at the growth rate of the tumor. We look at something called Ki-67 and mitotic rate. The Ki-67 is a stain that they do to see how many cells are trying to divide or be active at the time of the surgery or the biopsy. And then mitotic rate is how many cells are dividing at the time of the surgery or the biopsy. So this is how we grade neuroendocrine tumors. There's low grade, intermediate grade, and high grade for well differentiated. And these are the numbers on the right for mitotic rate and Ki-67. The cutoff is usually 20%. Anything above 20%, we sort of think we move towards higher grade. And then of course the poorly differentiated with Ki-67 above 20%, we tend to think of them as more aggressive cancers. So we call them neuroendocrine carcinomas. So there are some pitfalls with the pathology report. When you get a biopsy, you're just getting a small representation of that tumor. And it doesn't necessarily mean that we fully understand all the different areas. Sometimes when you biopsy different areas, you can find different growth, different grades, even though they're all well differentiated. So only time and following your imaging will tell us how well your tumor is going to behave or how things are going to go and how you're going to respond to different treatments. The patients who have well differentiated high grade tumors, and we had some talks on that earlier today, they can be either way. They can either follow the treatment pattern of somebody who has a slow growing tumor or follow the treatment pattern of somebody who has a fast growing tumor. So you have to, again, follow the patients to kind of better be able to tell how we should treat them. So laboratory testing for neuroendocrine tumors is another area where we can kind of get bogged down, and patients and physicians can become very focused on numbers. And sometimes that can be a good thing, sometimes that can be a bad thing. There's no great tumor marker for neuroendocrine tumors. I think we're still trying to perfect that. Most tumor markers are imperfect anyway. But chromogranin A is a test that different labs have different assays. So if you're a patient and you're getting your chromogranin A done at a LabCorp and then you switch to Quest, the range of normal could change, the numbers could shift, and that can cause some panic in patients. But remember that you have to be consistent with going to the same lab to get that number done so that you can watch the trend. And it can be affected by many different things. Acid reflux medication, inflammation, liver disease can cause the numbers to go up. So the trend can be useful for tumor markers, but we don't always, treat patients based on the tumor marker changing or shifting. We tend to treat patients based on what their scans are doing, at least I do. And we try to sort of do fasting blood work for some of these tests because, food can affect some of the testing. So there's other tests like pancreastatin, which is a subunit of chromogranin, which is supposed to be less influenced by drugs and medical conditions that some of us have available, some of us don't have available. So, but if you're going to draw that test and you can consistently draw that test, you can follow the trend for that blood test. There's pancreatic polypeptide. Not everybody draws all of these tests, but if there's a test that's elevated and you're seeing that it's trending over time, then you might be more concerned that there's something going on, the tumor might grow in the future. So again, the blood tests are imperfect, and we don't always treat because of the numbers changing. We tend to treat more if something's changing on your scans. So hormone production, that matters in terms of, what's causing your symptoms. Is it the hormones? Is it the medications that we're giving you? So we draw the levels to see where you are sometimes, because especially with serotonin production, when there's diarrhea, many things can cause diarrhea. So we sometimes have to see, is your 5-HIA level going up more, or is it something else? You have pancreatic problems because of the octreotide that you're on. So it's important for us to kind of draw those levels sometimes to guide management and treatment. Just because your hormone levels are going up sometimes doesn't necessarily mean that your cancer is worsening. So you have to kind of put things together with your blood tests and your scans. So these are all the different locations and all the different tests. So the serotonin can be produced by spread of a tumor from the small bowel to the liver, the appendix, about 10% of the time from the lung. And I sort of have the ability to draw the plasma 5-HIA, which is the breakdown product of serotonin, which is much more reliable to draw. And the patients usually have to be fasting for 8 hours. Otherwise, you can do the 24-hour urine 5-HIA, but you have to follow the food and medication restrictions for about 24 to 48 hours so that you can make sure the test is accurate. And of course, the pancreas, you can make insulin, glucagon, VIP, somatostatin. The stomach, usually we follow gastrin levels. And the colon and rectal tumors are usually silent. They don't make any hormones. So you can still check the levels, but they tend to not be functional. So for imaging for neuroendocrine tumors, for slow growing tumors, we usually do CAT scan and MRI with contrast. The tumors are very vascular, so it's important to give contrast so you can get the best look, especially for liver spread. If you don't give contrast, sometimes you might not see them very well. So the MRI is the better liver imaging test, and sometimes the surgeons like to see that test for their planning if they're going to do surgery. Otherwise, we try to use CAT scans if they're both equal. And of course, we do things like gallium-68 PET scans. Gallium is a radio tracer that picks up receptors for somatostatin on the surface of slow-growing neuroendocrine tumors. So that's a very good way of getting a whole body scan to see what is involved, where your tumor is. Is it in your bones? Is it just in your liver? Is it in the lungs? And sometimes we order an ultrasound of the heart for somebody who's making a lot of serotonin, because it can sometimes damage the right side of the heart and cause scarring. So what about fast-growing neuroendocrine tumors? Usually we do CAT scans with contrast. You can also do an FDG PET, which is when you take a sugar molecule and you tag it with a radio tracer and you inject that in the vein, and wherever there's areas of faster sugar uptake than the normal cells, then it will light up on your scan. For small cell cancer of the lung, we tend to do a brain MRI to make sure that there's no spread to the brain also. So, we try to base treatments on clinical trials. It's, we're doing better, I think, in the last, 5 to 8 years at getting trials up, open, running, and getting some conclusions, but we still have a lot of areas that we're working on where we're trying to get more data. And it's hard with rare tumors to try to get a lot of patients on a trial. So, we as physicians and as patients, like the more data driven we are, the better we can answer questions about what's the next best step for the patients. So slow growing tumors are typically hard to shrink because they don't grow fast enough for chemotherapy to have an effect of damaging the DNA and getting them to stop growing. So most of the treatments we have are really good at keeping things stable, but not so great at always shrinking things. Where fast growing tumors, because they grow so quickly, can respond really well to chemotherapy, but then they tend to come back. So, there's good and bad. So generally speaking, there are different types of treatments that we have. And when I started about 11 years ago, there was really the somatostatin analogues. And then over the last few years, there's been more and more treatments coming out, which has been very encouraging for us as physicians and for the patients as well. Somatostatin analogues is a class of drugs where you're making a long-acting form of somatostatin, which is a hormone that regulates other hormones. And it regulates how much insulin your pancreas makes in response to whether you're exercising, whether you're eating. And most of the neuroendocrine tumors have overexpression of those receptors. So we've discovered that the somatostatin analogs can slow down the growth of these tumors. So that's one class of drug that we use that tends to be well tolerated is an injection that you get monthly. And then there's pills that we have that can block blood vessel growth to tumors to sort of simplify things. There's everolimus, there's Sutent that we can use. We can also do liver-directed therapy, which is working through the arterial supply of the liver, and there's different forms of it. And, we're still not quite sure which one is the best form, but, you have to be a little bit careful with radioembolization because it can cause some damage to the normal liver and you can't do it continuously. And then, of course, chemotherapy, which works better for faster growing neuroendocrine tumors. It can work for slower growing neuroendocrine tumors, but again, it tends to be more effective the faster growing your cancer, just generally speaking. And of course, there's PRRT, which is a treatment that was approved 3 years ago, where you can give targeted radiation to the tumor using the somatostatin receptor. So again, the patients who are between slow growing and fast growing, mainly the well-differentiated G3 tumors, grade 3 tumors, it depends on what the imaging shows, depends on how the patient's scans are looking and how the patient's doing over time, which treatments we tend to pick. But your liver burden is important for us because most patients succumb to liver failure. So we usually are monitoring that very closely and making decisions about what you can and cannot tolerate. So this is how PRRT works. You have the somatostatin receptor on the surface of the cancer cell, and you have the somatostatin bringing this radiation emitter to the cells, and it gets engulfed by the cancer cell, and it releases a short burst of radiation inside the cancer cell to help control tumor growth and stop the cancer from growing. So fast-growing neuroendocrine tumors, usually we rely on chemotherapy, and there's 2 chemotherapy regimens that we've used the most, zolbetuximab and platinum etoposide. We have used immunotherapy recently because it was approved for small cell lung cancer, and we're still studying that in more detail to see where it works best for patients. It's sort of a different type of treatment pattern versus slow-growing tumors. So, just sort of some take-home points, like, generally, I would like my patients to understand where their tumor is, their stage, their treatment plan, their pathology report. And sometimes it can be overwhelming, which is why it's important to have family and to ask questions. And, finding a treatment team that treats a high volume of neuroendocrine tumors is probably in your best interest because there's not a lot of experience with neuroendocrine tumors in general in the community if somebody's not seeing a lot of it. And certainly a lot of us have collaborated with oncologists who are closer to you, location-wise, and we're further away, but we try to work together as a team to help impact your outcome and your management because, having a multidisciplinary neuroendocrine team can improve your survival. And finding a patient support group can be very helpful also because sharing stories and experiences for some patients can help them get to the right place and just feel emotionally like in a better place. So those are my take-home points. I know I went through that fairly quickly, but I want to leave time for questions because I know from the past that when I've done these breakout sessions with patient groups that there are always questions. So, I'll just close my talk. And then we'll introduce our panel. So I was going to have Dr. Rose introduce himself and tell us a little bit about himself.
Hi, I'm Dr. Bart Rose. I'm the director of our Pancreatic Biliary Disease Center here at the University of Alabama in Birmingham. I'm a surgeon. I specialize in NETs, and I also have a basic science lab studying neuroendocrine tumors.
Great. Dr. Del Rivero?
Yes, hi. Thank you for having me here today. And Jaydira Del Rivero. I am a medical oncologist. Something about me that maybe some of you don't know is I'm also board certified endocrinologist. So besides an endocrinologist and oncologist, you may understand that my area of research interest and clinical interest is in neuroendocrine tumors. I work with a lab in terms of translational efforts to develop better treatments for neuroendocrine tumors. Thank you.
Perfect. And Dr. White?
Hi, I'm Sarah White. I'm an interventional radiologist. I'm at the Medical College of Wisconsin. It's actually warm, not snowing, finally. I am the vice chair of research and also have a basic science lab looking at how to mitigate systemic effects of drug delivery. So can we deliver it locally without giving the terrible systemic side effects that we get if we deliver it systemically?
Great, perfect. Dr. Haddad.
Hi, thank you for the invitation. My name is Ghassan Haddad. I'm an interventional radiologist and nuclear medicine physician. I am the head of the radiopharmaceutical program at Moffitt Cancer Center. I treat patients with PRRT and other types of radiopharmaceuticals, in addition to interventional liver-directed therapy with a focus on neuroendocrine tumors. We also have a lab working on developing alpha PRRT for neuroendocrine tumors.
Perfect. And of course, I'm Sandy Kataya. I'm a medical oncologist. I didn't say that before. I work at Mercy Medical Center in Baltimore. And Dr. Odoriso is also with us. So we're just going to jump right in. And I'm probably going to direct the question to one person. And then if anybody else wants to chime in the panel, please feel free. So that way we're not all talking at once. So the first question is, are you ever concerned about intraradiologist reading reliability differences? So I guess I'll ask Dr. White to answer that first question.
Absolutely, of course. We always have our own view of how things look. So what I would tell you is the way to prevent that variability and if there's disease progression or not is to choose your modality. So if we're doing MRI, for example, I do MRI and then I continue to follow with MRI. So that way there's not variability with the imaging. The variability will just be within who's reading the scans. The reason that we like MRI, and Dr. Kotiah said this before, was that we can see things better. The T2 imaging is just a way that we can sequence, we can see it better. There's also a scan that's called DWI. It looks at the water molecules, and those water molecules are much more sensitive. That scan is much more sensitive in seeing small tumors that sometimes are missed on CT scan. So yes, there's intra-reader variability for sure, especially with neuroendocrine, because neuroendocrine doesn't tend to be one tumor. It tends to be scattered multiple little ones. And so a lot of times what we have to do with neuroendocrine, instead of just reading scan to scan, so a 3-month follow-up, we look at over time. So we'll look at 6 months ago, we'll look at a year ago and say, okay, maybe it only grew 1 millimeter between every 3 months, but you want to look at the long term. So at a big neuroendocrine center, I don't think that reads these scans very commonly. I think you're not going to be worried about it. I think you're going to be worried about it at a place where they're not seeing a large volume of these tumors. But certainly there's variability in how we read scans. So the way to prevent it, I think, is the strategy that I gave you guys.
Anybody else want to chime in?
Yes, in our center, we see a lot of, we read a lot of scans for neuroendocrine tumors, but we tend to globe these to be read by a few radiologists instead of everybody in the program. So then you can get, even the same radiologists can have variations in their reading. If you ask them to read a scan and then show them again, the measurements can change even by a few millimeters. But we try to minimize the variation by asking relatively the same radiologist to read focused on neuroendocrine. So they have a lot of experience on reviewing neuroendocrine tumor on imaging, and we try as much as possible to have the same radiologist read the previous scans so that you don't have this much variability. The variability is going to always be there. Even the same person is going to not going to read the same scan exactly the same, but you try to minimize it as much as possible by doing these mitigation techniques.
Okay, great. Thank you. So another question is, does grade migration actually occur, or is it mostly due to pathology sampling? Dr. Odoriso, do you want to field that one?
You're muted.
A biopsy is by nature is only a small piece of the tumor. So grade migration can happen if you were to take a biopsy at 2 different places in the same tumor on the same day. But But grade migration is less likely to happen when we actually look at the whole piece that we have, and we look at the most aggressive part of that any biopsy, and that helps prevent the grade migration. There are very few instances of grade migration in neuroendocrine tumors. What you might see is if you look at different tumors in the liver, they may have some variation, and that's sometimes called grade migration.
Great, thank you. Anybody else want to chime in or? Okay. So the next question is, have you had experience with patients getting false positives on certain parts of the gallium scan? Dr. Haddad, do you want to field this one?
Yes, I mean, every scan has its own false positive and false negative, and that's where experience comes in. Is very important because yes, you do have variations in on scans. Gallium 68 PET scan is different than indium 111 octrio scan, or you have now copper 64 DetectNet. So every scan, depending on the radio tracer, has differences. Even also whether it's .8, .talk, you have small variations. But if you do have any questions, there's always the role of biopsies and getting tissue. If you're looking at somebody who has widespread metastatic disease, and whether a small area is maybe a little bit of inflammation, like for example, we've seen recently patients who got the COVID vaccine and had axillary lymphadenopathy on a gallium DOTA-8 PET scan. But they also have liver metastasis, bone mets, lymph nodes. It doesn't really, most of the time the false positives are rare, and if you have a good experienced radiologist, that does not really affect our readings that much because you're not looking at very localized disease. And if you do have any questions, that's when we can go for sampling to determine whether it's real or not. For example, in the brain, sometimes we see a lot of meningiomas lighting up. Most of the time we look at it at the beginning, everybody was getting alarmed. The patient do they have brain metastasis or not? And we've had patients who actually did have brain metastasis. But most of the time it's a meningioma. So, but it doesn't really change overall the management because they're not too frequent. And most of the time you can just tell it if it's an location doesn't make sense, or it's most likely false positive. It doesn't really change the management that much.
So, I mean, we can flow into the next question, which is, is it okay for patients to switch from PET CT to PET MRI to lower radiation risk? And, both you and Dr. White maybe want to take a crack at that, or Dr. Rose, whoever wants to answer.
So, I mean, I can,
well,
definitely with the PET MRI, so you eliminate the CT part, and then yes, you do have a lower radiation, especially if you're doing PET CTs or PET MRI very frequently. The question becomes more actually, and most patients get CTs or MRI for their follow-up. So getting a PET CT or a PET MRI for regular follow-up is really not that used because of first reimbursement. Second, you don't really need that. So the question becomes actually whether you want to use a CT versus an MRI if you are worried about radiation risk. And yes, if you do an MRI, you have less radiation. I mean, you don't have less radiation. You don't have radiation with MRI, but you do have more radiation with the CT scan. There are only a few places who have PET MRI. So, going through that, it doesn't really add too much for neuroendocrine tumors specifically. There are other diseases with head and neck cancer. There may be a lot of more, value. you know, a little bit of extra radiation that comes from the CT, which is done at least, you know, the most recent in 6 months, the shortest time, it's not really going to add too much. So you're not going to find a lot of places doing PET MRI for neuroendocrine. Yes, in theory, MRI with a, you know, MRI instead of a CT will decrease your risk of radiation. So for most common follow-ups, instead of doing, for example, a CT of the abdomen and you want to follow up the liver metastasis, you can do an MRI of the liver. But then you also, every modality has its own pluses and minuses. With MRI, you spend more time in the scanner. Patients, some of them are claustrophobic. They don't want to sit there. A little bit of motion can get the images, you know, affected. But at the same time, you can see more lesions with MRI than CT scan. So you have to pick and choose between the two. But ideally, if you choose one modality, you should stick to it. Otherwise, it becomes very difficult to make comparisons with previous scans.
That's a very good point. Does anybody else have anything to chime in?
I would just say that the dotatate scan, you know, as far as radiation, so our preference in the abdomen is to get an MRI for the reasons I said before. But a dotatate scan can really be very helpful, and you don't have to get it all the time if you're looking for that primary and you don't see it on the cross-sectional, so the MRI scan. Sometimes it will take up those somatostatin receptors. You'll see them in the small bowel or wherever else the primary may be. And so sometimes we'll use that as a troubleshooting imaging, but we don't have to use that continuously to get the radiation from that. We may just use that troubleshooting or to see if the patient would be a candidate for PRRT. But for the most part, MRI, I think you can be managed on MRI if you can tolerate the MRI. Sometimes it's a little bit challenging in the chest. If you have disease in the chest, that can be a little bit of a challenge to see it on MRI. So we tend to like to get chest CTs for that. So I would say, you know, those are the considerations I would use.
Great, thank you so much. Dr. Del Rivero, do you want to field this next question? And, you know, I'm not sure of the details, but this person is mentioning that they have tiny, slow-growing tumors bilaterally in their lungs that are grade 2. And do they need to start medication to stop progression, and they're asymptomatic?
Sorry. Yes, thank you so much, Dr. Kotiah. I assume that maybe we're talking about lung neuroendocrine. So if we're discussing about lung neuroendocrine tumors, one of the things that we always discuss in all of, you know, with our NET experts is that to decide, you know, what is the tumor biology, what is the bulk of disease, whether even on these bronchial thymic neuroendocrine tumors, they also express somatostatin receptors, and whether that could be a treatment, either starting with a somatostatin agonist such as lanreotide or sandostatin, or whether we need to give further treatments. Usually, one of the things, it seems that base that is a grade 2, I assume this we're discussing maybe with a typical atypical lung neuroendocrine tumor. And if that's the case, one thing is that I like to, like any other neuroendocrine tumor, the first thing is I wanted to know what is the growth rate. And then once I establish what is the growth rate, you know, then I'll make the decision. If it's very slow growing or more rapidly growing, then I decide what will be the treatment algorithm. And I usually do also a Gallium scan to determine if this neuroendocrine tumor may also express somatostatin receptor. And if that's the case, usually what we use as our standard first line treatment, that will be a somatostatin agonist, either a sandostatin or an octreotide. So that's kind of like one of the things. It seems everything is stable. Maybe we may not necessarily start at this moment, but if things have started kind of like growing very slowly, maybe I will start with a somatostatin agonist as long as we have evidence that the tumor is positive on the Gallium scan. Otherwise, there will be other treatments, but first is to determine what is the growth rate in order to then decide what will be the best treatment option. What do you think, Dr. Kotiah?
Yeah, I think that's a very good answer. I think that it depends on you as a patient, how slow growing it really is. And, you know, the trap you fall into when you're observing patients is, are you looking at the scan from 6 months ago? Or are you looking at the scan from 3 years ago to see how things are evolving? Because if things haven't really changed too much and you're asymptomatic, and the treatment's not going to be curative, but more to try to slow things down, then your quality of life might be more important to you than starting treatment. If things are growing enough that we think that you're going to have symptoms, or that, you know, it's sort of like only, or you're getting nervous, you know, and then we can talk about treatment and what that entails and what the side effects are. So I think it's a discussion with each patient, you know, what they want to go through, and, you know, what other things are going on in their life, what other medical problems and things like that. Because some of these tumors can truly be very, very slow. I mean, I had a patient who had the same size neuroendocrine tumor, I think we all have, for like 10 years, 11 years. And I've had a patient grow 0.5 centimeter in 5 years. So it sort of depends. And another patient grew 0.5 centimeter in their tumor in a year. So it depends on your situation and how, you know, and what's going on. And, you know, I think that being asymptomatic is a good thing for us. We don't necessarily want you to be ill.
Right.
So the next question is, and there's no surgery question. So Dr. Rose is like, you know, just sitting there and waiting for patiently for a surgery question, I'm sure, and you can chime in anytime. But so building off the previous questions, a lot of imaging questions. So Dr. White and Dr. Haddad are going to be busy. Building off a previous question regarding ionizing radiation risk from imaging, is there a place of MRI imaging only in monitoring somatostatin receptor positive neuroendocrine tumor as systemic treatment continues? If so, when do you see the technique being used as the sole or perhaps alternating with PET, CT, NET spot, etc.? So whoever wants to take that.
I think it depends on where the disease is. You know, if it's predominantly in the liver, then I think, you know, following with an MRI is a good way to figure it out. If you have nodal disease, you know, we can measure on MRI, we can see the nodes, but we can't tell if there's cancer in there without getting a dotatate scan. So it really depends on where the disease is, but many of our patients, you know, you'll go a year with just getting MRI, and then maybe yearly we'll get a dotatate scan if everything else is going well and your chromogranin levels are coming down and all of the blood work is telling us that you're responding to therapy. You don't necessarily need to be getting, you know, CT scans and dotatate scans every 3 months. I don't know, Dr. Ghassan or anybody else want to?
I agree. Yeah, I mean, usually the dotatate PET CT scan, it's done when, you know, maybe at the beginning of if the patient is just diagnosed, has metastatic disease, you want to have a baseline, see how things are going to evolve. And then you start them on therapy, you start them on somatostatin analogues, and you start, you know, following them. If they have liver dominant disease or most of the disease in the abdomen, you can follow it, and they are SSTR positive, you can still follow them with an MRI. And then if there is any, because it's going to take a long time before you're going to even need to do something else. And then if you do have any progression, for example, on the MR, and let's say you're trying to determine whether the patient is going to be a candidate for PRRT, then, for example, in our institution, we would like to have a PET-CT dotatate within 6 months of the PRRT. Things are not going to change too much within 6 months. So in order to determine whether there was changes in the grading or differentiation of the tumors, if all the tumors are somatostatin receptor positive, and how much, because sometimes if you do have different populations, some of them are not positive, then you have to target those lesions specifically with ablation, embolization, or surgery differently, and then you can give them PRRT. So before a treatment, the PET-CT dotatate is really not used every few months to monitor the progression of the disease. Some people do that, and I see that in the community more so than in big centers, where patients are only followed with dotatate PET-CT scan. Not sure that is the best way of doing it, but in our institution we use mostly cross-sectional imaging. Maybe establish at the beginning with a PET dotatate, see what the somatostatin receptor status is of the tumors. And then if there is any changes and that will make a change in your therapy, then you may get another one.
I mean, I agree. I think that, and I'm not a radiologist, but my experience has been as a medical oncologist that there are times when I've had a patient get different scans because we can't always see things very well. And sometimes the MRI will show the liver burden better than the CAT scan. But sometimes the CAT scan is just as good. So I try to stick to the same scan each time because whatever shows the disease best. I think what you're hearing from us is there's not one perfect imaging or one perfect thing that you should always follow. the trap that I fall into with the gallium scan is that there can be like very early disease that's not actually showing up on the MRI or CAT scan, or it can be very sensitive. And you can pick up too many things and want a tendency to like over treat sometimes because of the gallium scan. So, you know, to me, if there's a lesion that's growing, you know, on a CAT scan or MRI, then I'm like, okay, that's clearly progression. If a small spot is popping up on a gallium scan, is that progression? Is that just like, you know, it's very sensitive, very early? Do I really need to change for that? You have to be careful with, you know, how you interpret, you know, progression on a gallium scan, and how you, you know, and whether you're consistently using the same scan every time, so you know where your patient's going in terms of imaging. I think great, I mean, very good points from both of you. So the next, we have a lot of questions. Wow, they're like popping in. So I'm going to try to move through a little bit more quickly. Having lung tumor ablation of tumors less than 3 centimeters, what is your opinion? So again, another like interventional question. So either one of you can answer.
Yeah. No, I think
That is
ablation is a great modality to use in the setting of, you know, limited disease. So if you've got 20 lesions, doing ablation doesn't make sense. It also, you know, I'll let Dr. Rose speak. But if you have it isolated to a particular part of the lung, sometimes it's easier to wedge out. You can get multiple tumors if they're close together. If they're, you know, one's in the left and you've got one in the right and they're less than 3 centimeters, then, and that's all the disease you have, then, you know, doing an ablation probably does, you certainly can do that, and you can be almost, you know, a curative to that lesion. So it just makes but if you have lung lesions plus lymph nodes plus liver, does it make sense to ablate something in the setting of multi-system disease? Then probably it doesn't make sense to do an ablation. So again, it depends on the whole picture, and the location is really important for ablation, you know, versus does surgery make more sense, or does ablation make more sense if that is the only focus of disease that you're seeing?
Yeah, I think that's exactly right. So, I mean, really the role for surgery is going to be if you think that this is potentially the primary, or they have very limited disease and you have a good chance of removing, if not all, at least most of the disease with an operation that is not going to be excessively risky to the patient. And so if this is the original tumor, then I think it makes sense maybe to follow a surgical approach, and even endobronchial can be an option too for people who maybe can't tolerate a lung resection. That's also been shown to be effective for some smaller tumors depending on the location. So I think ablative treatments can be very helpful if people are not candidates for more curative therapy.
Perfect, thank you. So let's knock out a couple of these imaging questions here. For patients with GEP-NET, how often should the patient be getting a CT of the chest? And is CT with contrast better, or MRI with contrast better for visualizing lung lesions? I'll let either one of the radiologists or Dr. Odorisa, whoever wants to answer these two questions.
I can answer the one for the chest. We don't really get MRI of the chest with contrast to evaluate the lung nodules or see the progression. And you don't even need contrast to localize lung nodules and following them. You just need the regular CT scan of the chest without contrast.
Perfect. And then in the setting of, I think, you know, in terms of routine CAT scan of the chest after somebody's had resection of a neuroendocrine tumor on this GI or the pancreas, that's not really recommended to get a CT of the chest. I mean, I think NCCN had at some point recommended a yearly chest x-ray, but we usually tend to worry more about, I think, the liver and even the bone lesions. For me, they haven't always been a problem. They haven't really been a big problem, but I think that we don't routinely recommend CT chest for surveillance for people who have resection of their GEP-NET tumors. You guys can correct me if I'm wrong. I think if you know that there's lung lesions in that patient and you've discovered lung nodules and you're worried, then of course you're going to monitor the CAT scan of the chest. You know, usually we don't do it too often because the slower growing neuroendocrine tumors don't need it to be done every 3 months or so, maybe every 6 to 12 months. But I don't think and if anybody else has a different answer, please chime in.
Yeah, I think for post-resection, it kind of goes to how many risk factors they have for recurrence. So, you know, what was the grade on the resected tumor? Were there lymph nodes involved? Did you get everything? And so I think if they're at a high risk for recurrence, then I'll alternate between what we call anatomic imaging, or, you know, CT or an MRI of a very specific area, usually the abdomen if this is a GEP-NET, and then I alternate with the dotatate scan. And I think that there's, the evidence for that is not great yet because we haven't had this for years, but my feeling is that I get a good sense for a very high risk of recurrence disease for early recurrence, and I get a whole body imaging. And so I'll do, kind of offset by 6 months, a yearly CT or MR and a yearly dotatate. And I'll do that for the first couple of years and then maybe expand that out if they haven't recurred in that time frame.
Have you had a lot of patients with GEP-NETs get into trouble with lung nodules? I mean, that has not been my experience, but I'm just curious.
It's rare, but it has, and it's not only the lung, but I think the reason for doing the dotatate is also bone and other kind of occult areas that, and lymph nodes too. So sometimes the lymph nodes can be so subtle in the regional area that unless you are looking specifically for it, you may miss it on the CT or the MR, and then you pick it up on the dotatate, and then you look retrospectively and say, oh yeah, that was there. But they can be very subtle findings, and especially depending on what the patient has had done previously, it can be challenging to find.
Okay, perfect. So then the next question is, what are the absolute contraindications to PRRT? Is previously directed therapy a risk factor?
Yeah, so for PRRT, there are a few things that we look at to determine whether the patient can tolerate the therapy or not. To start with, if somebody has very poor performance status, and we've had these patients, we know patients referred for PRRT when it got first approved because patients were waiting for it. So there were very advanced stages that, if they have very poor performance status, that they're not going to tolerate the therapy. Low renal function, if the GFR is low, less than 30, definitely. 40, we use that relatively to separate patients. So if they have abnormal kidney function, that would be a contraindication. If they do have from the beginning liver dysfunction, if they have significant amount of disease in the liver and they have liver dysfunction, that would be an indication. If there is low blood count, if their platelets are low, if the white counts are low, because you know with PRRT that many patients will have a decrease in their counts. So if you already have patients that have pretty low hemoglobin, pretty low platelets or white count, then they would not be candidates for PRRT. Then also by imaging criteria, when you look at the scan before you start the therapy, if you do have many lesions that are not positive on the dotatate scan, then PRRT would not be a good indication because you can give it and it's not really going to do anything because it's going to concentrate only on the few lesions that are positive on the dotatate scan. And a more recent we consider it as an absolute contraindication. We started considering that is if the patient have significant amount of peritoneal disease, because we've had patients who you treated only with one cycle and they went completely to a frozen abdomen, complete bowel obstruction. So we're not talking about few peritoneal lesions or few mesenteric lesions, but we're talking about extensive peritoneal metastasis or mental caking. That would be considered as an absolute contraindication too.
And then what about the follow-up question of, can it cause lowered blood cell counts, which we know it can, sometimes permanent? Can this be reversed over time?
Yes, so yes, it can. And then that's why before each PRRT treatment, we check labs and we make sure that the patients are still tolerating the therapy. If there is a mild decrease in the counts, we've had instances where we have to decrease the dose. Currently, there is a standard 200 millicurie that is given to all patients. But if the count started decreasing, then we may decrease it sometimes by 25%, sometimes by 50, or we give either 150 millicurie or sometimes 100 millicurie. We're not yet using dosimetry to do more refined dosing for patients, but we just go by these recommendations. And sometimes if the counts do not really come back up, we may have to stop the treatment completely. But in many instances, if there is a small dip, they may come back up if we give time for the bone marrow to recover.
Right, it can take months, right, for some patients, so.
Yes. I mean, we're a little bit more conservative. So if we see a dip that is significant, we sometimes have to stop the treatment completely.
Okay, so next question, maybe Dr. Odorisio wants to field this one. A pancreatic neuroendocrine tumor who has bone mets in the ileum that's sclerotic and on lanreotide with pretty good control of symptoms, like the person said, diarrhea and malabsorption. Any value in having a bone density scan, blood work for magnesium, calcium, vitamin D, and potassium. And they also want to mention that they have a labrum tear in their hip. I'm not sure that that's quite related to anything, but certainly, like, please, Dr. Odorisio, if you want to chime in and answer this question for her.
Well, in terms of a pancreatic neuroendocrine tumor with bone mets, I think that the baseline scan would be a gallium dotatok or dotatate scan to know whether those bone lesions are positive in uptake. And this would actually dictate for us how often to follow and with what lesion. I don't think MRI is usually very good, and any of my colleagues can disagree with this if they have a better perspective. MRI is not that good for bone lesions. So I think for bone lesions, the gallium dotatate is the best way to follow.
Have you seen a lot of fractures from neuroendocrine tumor involving? I mean, I've sort of had this with bone mets. Most of the patients have actually done well. I don't always initiate bone modifying agents like Zometa or Xgeva in those patients. I tend to kind of just follow to see what happens. But have you started a lot of bone modifying agents, or have you seen a lot of fractures from bone involvement with these neuroendocrine tumors?
Actually, we actually have seen healing of bone lesions with the PRRT and have converted patients from very high risk of bone fractures to hardly any risk of fracture with the PRT. So we would not use that as a contraindication to PRRT, but we would follow it closely with the dotatok or dotatate scan.
Great, and then this kind of flows into your area of the woods. The patient asked about doing sort of gallium imaging or doing imaging routinely in young adult patients with MEN1 or sort of high risk populations.
The MEN1, actually, this is a better question for Dr. Del Rivero. So I hope she chimes in.
Yep, she will. I'm sure she will.
So go ahead.
I just want to make a comment on the previous questions because I think they were asking about the validity of DEXA scans, and the only way that I could request a DEXA scan is in patients with MEN1. And the reason why is because patients that have MEN1, they have the activated parathyroid gland. So basically they have parathyroid adenoma and they cannot get all the calcium out of the bones. And then you have very high calcium levels that in those patients having a DEXA scan as a screening for those patients every 2 years is indicated, especially in the setting of having this elevated calcium and elevated hormone related to the parathyroid gland. And the reason why is because if that's the case, you need to do dedicated intervention for that. And that's the only way that I could think that I could, or request a DEXA scan in the setting of these neuroendocrine tumors. Other than that, I don't think there is a need to do any DEXA scans. And even if you want to, and maybe our radiologists here may comment on that, but you don't want to do a DEXA scan in the setting where there is a bone metastasis because it's going to give you false reading, and you don't want to. And I don't think that's needed in this situation. I don't know if that answered the question.
Yes, and I think the other question was, for a high risk MEN1 patients, doing like surveillance with gallium scanner with imaging for those young patients.
Yeah. Yes. And yes, thank you for that question. I think that this is kind of like the standard that we do. I mean, it's patients with MEN1 patients, they do undergo like different screenings because they don't have the pancreatic neuroendocrine tumors. They may have the pituitary adenoma, they may have the parathyroid adenoma, they may have the pancreatic neuroendocrine tumor. So there is other neuroendocrine tumors associated with the MEN1. Once we know that somebody has a pancreatic neuroendocrine tumors related to the MEN1, I usually obtain a baseline Gallium scan, but I don't necessarily follow those patients with surveillance of the Gallium scan. And one of the reasons is because I think there was a discussion earlier, is because there is not, it's very difficult for the insurance to approve it on a regular basis as surveillance. So usually have a baseline Gallium scan, and then after that, I do it as needed basis. Now, the question is about kind of like, I always kind of for my MEN1 patients is about the radiation exposure as well. Like they have all these scans every year, every 2 years. And it's like, how often do you do the imaging studies? And it's usually in patients with MEN1, I also check their hormones on a regular basis, the hormones for the pituitary, the hormones for the parathyroid, the hormones for the pancreas, because most of these MEN1 patients, they may have more of pancreas neuroendocrine tumors compared to the small bowel neuroendocrine tumors. And sometimes by checking these hormones on a yearly basis, that can also indicate what kind of imaging studies I need to do on that. But on average, I would just say in patients with MEN1, we do imaging studies every 2 years.
Great, thank you for that very nice, thorough answer. I like that. Okay, so Dr. Rose, I think people heard me, so you have some questions to answer here. So when would you remove a diseased lymph node, inguinal node especially, and looking for size parameters and benefit risk ratio with lymphedema? That's the first surgery question.
Yeah, I guess it kind of depends on what the goal is. If this lymph node is causing symptoms, if it's large and causing pain or eroding through the skin, then I think that makes sense. But just having an enlarged lymph node, if you have additional disease elsewhere, I don't think there's really an indication for removing a single lymph node, short of it being symptomatic. That being said, if it were to be done, removing a single lymph node is unlikely to cause any significant lymphedema. Usually where you see that is if you're doing what's called an inguinal lymph node dissection, or you're taking all of the lymph nodes in a region, that disrupts the drainage enough that you're at increased risk for lymphedema.
Perfect. And the next question is, I have a neuroendocrine tumor in the duodenum/antrum and several on both sides of the liver. I'm assuming that's what it meant. I have had chemo, done monthly standostatin, and recently had Y90 to the liver. When is surgery of some sort indicated at all? Liver metastases were reduced by about 25% after Y90. In the last 2 endoscopies, the antrum tumor could not be visualized and the biopsy was negative.
Yeah, that's a challenging one. I think a lot of that's going to depend on what the liver disease looks like. I'm assuming because they got Y90 that it's pretty extensive and probably not curable by a resection. When we decide whether or not removing the original tumor makes sense, because there is some evidence by removing the original tumor, even if you can't remove the distant completely, will improve survival. You have to weigh the risk and benefit of the actual operation. And so for a tumor that's in that part of the body, it's probably going to be a Whipple procedure, which is not a small endeavor. So when you look at somebody who has disease that's beyond that area, you know that you're unlikely to cure them with an operation. And so what you're trying to do is either improve the quality of their life somehow or extend their life. And that really comes down to how well you think they could tolerate such a big operation and what extent of the disease you think that you can get out. And so it becomes a very personalized recommendation.
Right, thank you for that. So the next question is, had a false positive lesion that lit up on a dotatate a year ago and surgery was performed, biopsy was negative. Should I get another gallium scan? So back to the radiology folks in the group, Dr. White, Dr. Al-Haddad, whenever you want to field this question.
I mean, not sure where, and it's very difficult to know where is exactly the lesion. I mean, if it's been a year and as a fishing expedition, yeah, I maybe would do another gallium dotatate PET scan.
Dr. White, any different viewpoint, or you agree?
Yeah, I mean, without knowing the location of it, obviously biopsies can have false negative rates as well. I think if the patient is asymptomatic and it was a low probability of any disease and it was an excisional biopsy rather than a needle in something that maybe we missed, because there's a lot of heterogeneity when we do biopsies. Maybe there's no indication. It just depends on how confident the surgery and pathologist was that it was negative. If it was really a surgical excision with no known disease, then I probably would not recommend any follow-up imaging. I think it really depends on what it was, where it was, and how certain we are that we actually got what was seen on the imaging.
Okay, perfect.
I just want to make a quick,
yes.
because I think there was a previous question mentioned something about liver-directed therapy, the risk of liver-directed therapy in patients who, or PRRT in patients who had previous liver-directed therapy. I know that we didn't really touch on that, but very quickly, we really, after PRRT was approved, there was a little bit of concern about all the previous liver-directed therapies and adding PRRT to that, whether that's going to increase the risk of liver dysfunction. We had all data on very small number of patients, one of them from Penn, maybe less than 20 patients, and another one from Houston, very heterogeneous population in those cases that included patients with bland chemo, embo, Y90, so they're all mixed of treatments. And in one study, the patients were heavily pretreated, showed increased risk in patients who received PRRT after, but that was more related to the Y90. They thought it was more related to patients who received Y90. The study from Houston didn't really show much increased side effect in patients who received prior liver-directed therapy and then PRRT. We looked at it specifically for bland embolization and PRRT, and we reviewed about 80 patients. There was no increase in liver dysfunction in patients who received liver-directed therapy before, bland embolization specifically, and PRRT after. So with Y90, it is a little bit tricky. So you have to see how much the patient received. If it's only in a small area, if it's radiation segmentectomy, meaning high dose, ablative doses in a very small area of the liver, it's still going to be okay with PRRT. If it's bilobar diffuse disease, you have to be a little bit careful.
Yeah, which somebody mentioned, like I had mentioned in my talk about radioembolization and being careful with those things. You can't get it multiple times. And somebody said, can you elaborate on why? Are there any treatments that might be eliminated due to prior radioembolization? I will just tell you that the reason I said that was I have lost about 3 patients to liver failure from radioembolization who had very slow growing endocrine tumor and not that high of a liver burden. They weren't really treated. They came to me as second opinions and sort of transfer of care. And that's tragic when you lose somebody to treatment toxicity versus disease itself. So that's why I'm a little bit leery about radioembolization in the patients who have very slow growing endocrine tumors, especially. But can the interventional radiologist comment on, what are your concerns about radioembolization in terms of, does it eliminate any other treatments for you, and why can it only be done once? Or, I mean, I know it can be done sometimes, rarely more than once, but can you guys comment on that?
So I think there's a lot of planning that goes into a Y90, and as you said, the extent of disease is critical. So if you have a very low tumor burden, the chance that you're going to get damage to the normal liver is going to be very high. And so at my institution, we will not treat a patient that has very low disease volume, because the way the beads go, the way that Y90 works is I infuse it into an artery and it goes into the areas that have more blood flow, and tumors tend to have more blood flow. So if there are very few tumors, the beads are just going to go to normal liver parenchyma, and so the liver is going to be damaged. So when we looked, over long term for this patient population, so patients that had metastatic neuroendocrine, we looked over 4 years, and we looked back and we said, how did we do? About 30% of patients are going to get a problem. They're going to get cirrhotic looking livers, so sick looking livers. Now, how many of those patients are symptomatic? It's about 15%. So what does that look like? They're going to develop fluid in their belly. They're going to develop distension of the veins. They're going to have their blood counts are going to go down as a result of it. So looking and being very careful about Y90 and making sure you have enough disease, not too much disease, and how we're dosing it. So the way we used to dose it early on is very different than the way we dose it now. And I would say a lot of us are reserving Y90 for patients that have really progressive disease. So if you're in grade 3 and you're really progressing, you're in grade 2 and you have a really large volume of disease, that's when we'll do Y90. Otherwise, as Dr. Ghassan mentioned earlier, we tend to do something that's maybe not going to be so toxic to the liver. We'll do something like bland embolization, which are just teeny tiny little beads that block off the blood supply, or we'll do chemoembolization, which is, infusing a chemotherapy directly to the liver. Now, why we make and how we make those decisions varies, doctor to doctor, but really if they have lots of blood taking things to the tumors, it doesn't matter which therapy you get. At my institution, we really reserve Y90 for those patients that have disease that's rapidly progressing, in patients that are very symptomatic, that are losing weight, that the cancer is starting to win the battle. Those are the patients that we say we need to be very aggressive with these patients. It doesn't preclude us from going on and doing further therapy. If we do a Y90 once, you have disease progression in the liver, that doesn't mean we can't come back later on and do something else like the beads or the chemo. But at my center, we tend to start with chemoembolization or bland embolization, just because we know that that is less likely to develop into something worse for the patients later on.
Thank you so much for that explanation. Okay, so the next question is there a role for focused radiation for a cluster of positive lymph nodes? Is this based mostly on the growth rate? So just to sort of answer generally about lymph nodes, there's 600 of them. They're all over the place. They're all interconnected, and they can carry disease. That's usually, there's two ways, either blood or lymph nodes, that cancers can tend to spread to other organs. So, usually when you're talking about somebody who has lymph node involvement, it's because it's spread from someplace else. And if you're going to give treatment to that area, it's usually because you think that it's causing symptoms or it's causing some sort of complication, and you want to try to give something localized and focused to that. So, I generally, I'll wait for the others to chime in. I generally don't recommend focused radiation to like lymph nodes, and you can cause damage to the lymph node. It can cause lymphedema, which is a complication. So it's not so much based on the growth rate. It's based on, are there other options? What is that person looking at? Are they symptomatic? But does anybody else want to chime in for that particular question?
We've done localized radiation, for example, in the porta hepatis. If we've done other local regional therapy, let's say for the liver, everything looks stable, etc., and then a single lymph node is growing, there are instances where we work with our radiation oncologist and they just target. Now, is that based on strong data and saying that that affects overall survival? I'm not sure, but if everything else is under control and you have one lymph node that is growing, and then before it becomes an issue and causes compression on the structures around it, especially in the porta hepatis, we may sometimes use localized radiation, external beam radiation to that area.
Okay, and then the next question is for Dr. Rose. When or why do you take out the primary tumor? Can surgery for that be worse than letting things go, and specifically a Whipple?
Yeah, so in general, the reason we perform an operation to remove something is, either we think we can do it for a cure, because this is a high-risk lesion and we can get all of the disease that we know of out, or we can do it to control significant symptoms that can't be managed with medication or something else. And so, a Whipple is a big operation, but in experienced hands, it can be done very safely. So I think that if it's something where you have a neuroendocrine tumor that is a high enough risk or causing enough symptoms, and it's possible to remove all of the known disease with that operation, then I think that makes sense. But I would strongly recommend having it done at a place that does it a lot.
Thank you. And then since you're up anyway, there's a question for you about how do you assess the high risk of recurrence in patients?
Yeah, so I think you look at some of the features of the tumor when you remove it and say, how aggressive does this appear under the microscope? And what we call that is differentiation. And usually the tumors that we're removing are well differentiated tumors. Poorly differentiated tumors are not generally resected. And then we look at the grade of the tumor. And then we look at whether or not lymph nodes or what are called margins are involved. And so the margins are the areas that we cut through in the operation. And if we look at that cut edge and there's still cancer at that cut edge, well, that means there's cancer on the other side of that cut edge, which is still inside the patient. And so, there's a high risk that that cancer is going to come back. If there's lymph nodes that are involved, that means that this cancer is already starting to spread. Is it possible that we removed all the lymph nodes that are involved and we cured them? Yeah, that's possible. Is it also possible that something else got beyond that lymph node and it's just too small to see right now? That's also very possible. And so I think for those patients that have a lot of lymph nodes that are involved, they're at a much higher risk for recurrence. And those are the people that I'll typically follow very closely to monitor for early recurrence.
Thank you. So we have about 8 more minutes left. I'm going to try to get through as many of these as I can. I'm probably not going to get to all of it.
I'm right now, I'm trying to answer by typing, if possible, for small, quick answers.
Okay, perfect. Oh, look at you. I like that. Multitasking. Perfect. So this next one is sort of a controversial question. I think a lot of us run into that. What are the treatment or diagnostic options for someone who with presumed neuroendocrine tumor, very symptomatic, but no tumor is found on all of the imaging and presumably no receptors? So I don't know if Dr. Odoricio or Dr. Del Rivero want to field that question.
I can start, and maybe Dr. Odoricio can also comment, as well as Dr. Kotiah, because I completely agree. We get a lot of these consults, or site consults, about that a patient that have flushing, diarrhea, and all those symptoms that are very similar to carcinoid syndrome. And then one of the things that comes to mind is, like, could this be a carcinoid tumor? And then they go into imaging studies in Gallium scan, and sometimes we don't find the source. And in those situations, I really want to acknowledge all the patient's symptoms, and there could be other causes as well of these symptoms. Like, for example, one of the things that I like to rule out is a condition called mastocytosis. So mastocytosis is basically a overproduction of these mast cells that can be localized in the skin, can be localized in the gut, and that can also cause flushing, that can cause diarrhea as well. Other conditions, for example, that I have seen with flushing as well is pheochromocytoma, which is another neuroendocrine tumor as well. And usually these pheochromocytomas, they call it the great imitator because they sometimes has non-specific symptoms as well. And I usually like to do a hormonal evaluation to know if maybe that is the cause. I mean, there are other things that we can consider as well as the cause of the flushing and as well as diarrhea that I don't think any of us would like to ignore. And I think we need to make everything possible to really know what it is. One other thing that I have seen as well, but it's more rare, is another endocrine tumor, and that's called medullary thyroid cancer. That can also cause some flushing, diarrhea, depending on the levels of hormones that the tumor produce. I usually like to do a baseline hormonal evaluation in those patients as well. That's usually what I start if I feel like there is no evidence of neuroendocrine tumors I have seen. Now, in despite of all of this, and the symptoms still continue, and that's why I wanted to know your thoughts, Dr. Odoricio, Dr. Kotiah, what do we do? Because I understand that these symptoms can sometimes be quite debilitating for some. And I again, there is something that could we give some astatin agonists like lanreotide and statin. Some of them, they feel better after this. So I don't know, what do you think, Dr. Kotiah, Dr. Odoricio?
I'll let Dr. Odoricio chime in because, I certainly, have, my own feelings about it, but I want to see what she thinks.
Well, we actually did a study in which we looked at the ability of the gallium, this was DOTA-TOC scan, but it doesn't matter whether it's DOTA-TOC or DOTA-TATE, the ability of that scan to detect unknown primaries. And this is where the reader of the gallium scans is extremely important. So we found that 60% of unknown primaries could be localized with a good gallium DOTA-TOC DOTA-TATE scan. And we really support the use of it in terms of tumors that may be symptomatic, but you can't find the tumor because it's often in these primaries, the tumor is small, much smaller than the metastatic lesions will be. So we do think that the gallium scans are extremely important in helping find unknown primaries. And, you know, Dr. Rose may want to comment on this, but I think he mentioned earlier that there is evidence now showing up that removing these small primaries may actually help lessen lessen the symptoms and can prolong the life of that patient.
Yeah, I think there is, as Dr. Odoricio mentioned, there are in some surgical series some suggestion that patients who have their primary removed but not their metastatic disease will live longer. You know, that may be a component of selection. You know, if you were healthy enough to have an operation, you were healthier than the people who weren't. And so there may be what we call a selection bias there. But even when trying to adjust for that, the thought is that maybe there's something that is being secreted by these primary tumors, a hormone or what we call a trophic factor, a growth factor, that could be driving the tumors that have already spread. And you take that growth factor away and they grow slower. Also for small bowel tumors in particular, they will typically grow. And thankfully, a lot of patients with neuroendocrine tumors, even with spread disease, live a long time. So if that small bowel tumor grows large enough, it will eventually cause obstruction. It can cause significant diarrhea. It can cause abdominal pain and cramping. So by just removing that primary tumor, yes, you may have some benefit on reducing the growth of the tumors in the liver, for example. But also you're getting rid of a lot of symptoms that the patients may have been dealing with for the last decade and just couldn't attribute specifically to this little tumor.
Thank you. So I think we'll take one last question. And if you guys want to, any of you guys on the panel want to email back some of these answers, I can do it as well. That if it's something simple, certainly feel free. I know some of you have been doing that already, so thank you. So there's some conflicting studies looking at the risk of other cancers after neuroendocrine cancer. Some papers say it increases the risk of other cancers. Some papers say that they don't. Do you have any updates? I mean, I know that there's some increased risk. I think it's like 18% chance that you can have a concurrent cancer of the GI tract if you find a neuroendocrine tumor of the GI tract. I think there's some data for that, but I don't know that it increases your risk of other cancers necessarily. Obviously, if you have a fast-growing neuroendocrine tumor and you're a smoker, smoking can increase your risk of other cancers like bladder cancer and kidney cancers, but I don't know if anybody else wants to chime in to answer that question.
I mean, I'm not the right person to answer that, but as far as PRRT, for example, it does increase the risk if the patient receives PRRT. We never mentioned, but there's a small chance between 0.5 to 1% of developing acute myeloid leukemia, and that's with a median for that to occur about 55 months. So yes, there is a very small risk for that, but that's related to the therapy itself.
Yeah, not the neuroendocrine tumor. Okay. So I think, we're going to wrap up. We'll try, I'll try, or one of us will try to sort of type the answers to the last two questions. And, I'm not sure if Cassandra is on I think she is on the line. I don't know if there's anything else you want to say or whether we're just finished for the day. And we thank you for joining us. And it was enjoyable for me, and I'm sure I'm speaking for the rest of the panel. And we thank you for your questions and for your interest. And if there's anything else, please feel free to contact us.
Great.
Thank you.
Thank you, everybody.
So much. Thank
Bye.
you. Pleasure to be here with you all.